Thank you very much to my friends from Latino-American Society, and welcome in Italy, welcome in Rome. My task in these 10 minutes is to speak about posterior shoulder instability. And if you look in the literature, there are a lot of classification. Just some fast reminder, the stability in the glenohumeral joint is guaranteed through the ligament, especially at the end range of motion, and the bone integrity in an anterior and posterior instability is guaranteed by the glenoid, by the glenoid integrity and humeral head integrity. So ligaments are so much important in the end range of motion, and the mid-range is guaranteed through the bone. In anterior inferior instability, we describe the glenoid tract concept that is interesting because keep in importance the interplay between the Hill-Sachs lesion, I mean the bone defect on the head, and the bone defect on the glenoid. So the interplay between the bipolar lesion is one of the key points in anterior inferior instability. And with Ishitoi, we introduce the concept of the glenoid tract to measure the Hill-Sachs, especially to understand if the Hill-Sachs is going to engage or not to engage in abduction external rotation. This is the concept on off-track lesion in anterior inferior instability. Going to speak the posterior instability, I really enjoy the very clear classification of our friends Philippe Moroder that is called ABC classification. A are the acute first time dislocation, B the recurrent dynamic posterior instability, and C are the chronic static. Acute can be divided in A1 subluxation and A2. A frank dislocation is acute first time subluxation and dislocation. Then we have a group B in recurrent dynamic posterior instability, of course, that are divided in B1 functional and B2 structural. You can see a very nice figure what we mean for functional posterior instability or structural. The first one, B1, is the patient that is going to dislocate the shoulder with a functional movement. The B1 are controllable positional. You can see these patients. It can control in abduction, the dislocation. It can dislocate and reduce by himself. Can be not controllable positional, like this patient that is not able to control the dislocation. Controllable not positional, you can see the position of the arm is in adduction. And then we can have non-controllable no positional. Of course, we have different video that can show this kind of pathology. Then very interesting are the chronic static. Speaking about this, always keep in mind the B2 described by Jill Balch is called C1 in this classification, and the acquired static that sometimes in emergency are missed that we call the C2, which is the treatment. So the first time you have to check type of instability, pattern of the lesion, age, elapsed time, and goal of the patient. Usually, most of the time after the reduction, the mobilization is in external rotation. Otherwise, if you put the arm in internal rotation, you can engage the reverse Hill-Sachs that is anterior in this case with the most posterior part of the glenoid. If you have a recurrent dislocation and is only soft tissue problem, or you have a minimal glenoid bone loss posteriorly or very small reverse Hill-Sachs, the arthroscopic treatment is our choice. It is a general choice. But very important is that you are able to study the bone loss, especially the interplay between the reverse Hill-Sachs and the posterior bone loss. At this point, you have to study on the axial view the position of the pulley, the position of the reverse. You have to describe an angle between the pulley and the most medial part of the Hill-Sachs. We call this gamma angle, another angle that is between the Hill-Sachs and the most posterior part of the glenoid. We call this delta angle. If the delta angle is inferior to 90 degrees, there is no problem. Does not engage with the posterior glenoid. If it's more medial, like in the Hill-Sachs, is If it's more medial, in internal rotation, you have a gamma angle that is superior to 90 degrees, and this potentially can engage with the posterior glenoid. If you have a posterior glenoid bone loss, like in on-off track lesion in the anterior, you have much more possibility that the reversible sacs is going to engage on the posterior bone loss. So it's the same concept of the anterior instability. In those cases where the culprit is the bone, for example, the reversible sacs lesion, we use with excellent results the McLaughlin technique. It means a transposition of the lesser tuberosity. You can see that we are debriding the reversible sacs, we perform an osteotomy of the lesser tuberosity, and we are shifting in a more medial position, fixing on the reversible sacs, the lesser tuberosity, of course, the subscapularis tendon that is attached. There are different ways you can use, you can perform this technique. We most of the time use anchors double loaded, as you can see. Usually double row, medial and more lateral, to have a very good compression and to keep the repair stable. And this is our results in the right shoulder at 6 months. And in our hand, this surgery works very well, especially if there is a culprit of the bone that is the reversible sacs, even if we don't fix the posterior labrum. This is the X-ray control after the surgery. You can have also osteochondral lesion during the mechanism of the lesion. You can fix this kind of lesion. I think that is very important to keep in mind that when we speak about anterior and posterior instability, there are, of course, bone loss on the glenoid, but there is a very clear difference in posterior instability and in anterior instability. In posterior instability, the head is going to dislocate in more posterior inferior part of the quadrant. So most of the time, the bone loss is posterior inferior. In anterior instability, most of the time is more anterior than anterior inferior, according to the Ishitoi paper. The lesion in posterior instability extend from 645 to 928, according to Matt Provencer study, and in anterior instability is closer to 3 o'clock. Very important is the angle respect to the long axis, that is around 30 degrees in posterior instability, and very, very interesting, according to Ishito Yamamoto study, in anterior instability, the bone loss that once again is between 3 and 4 o'clock is parallel to the long axis. So you can see that there is a different pattern, a different morphology. In traumatic posterior instability with a bone loss that is superior to 10%, of course, the platform reconstruction through iliac crest graft is one of the key points. So you have to perform a graft on the posterior part where the bone loss is, usually between around 6 o'clock. And of course, you have to perform a shift. The surgical treatment goal is to improve the posterior platform, exactly as we do with the Latarjet when we perform the treatment for anterior instability. The problem is maybe an unresolved problem when we have a dysplasia of the posterior glenoid that is different from a classic glenoid bone loss because a traumatic issue. In the dysplasia, of course, you have to study very well the morphology of the glenoid, and the literature advises osteotomy with the bone graft into the osteotomy. And of course, a very accurate reconstruction of the posterior capsula and the posterior tissue. Thank you very much, my friend.